me share my and show you how I do it. So, okay, let's see. Do you all see the Bone Health Interest Group page? Okay, so when you go to our page, you'll see the future talks, but if you want to view a past recording, you have to scroll back like this. Hopefully it will work. Okay, it's not working, but you should be able to scroll back to the previous month and click on the link to view the talk. Maybe if I do it this way. Yeah, it doesn't seem to be working, but you can go back in the calendar and there is a password that you have to copy and paste into Zoom, but the password is right there on the front page. Don't know why this isn't working right now, but that's the way you view the past recordings.
Yeah, and I was able to. I think it just takes a time to load. I was able to view them. Yeah.
So for example, if you wanted to watch Andrea's talk, which I highly recommend, here is the link. Here's the password. So you just copy this and then you go on this Zoom link, paste the password in, and you can watch the recording. It will come up here. So that's how you do it. We are trying to find a better, more user-friendly solution, but that's what we have for now.
Okay, I think we have lots of wonderful questions. So I mean, the first question here was about medications after Prolia. So if Prolia was not working or there were side effects, what are some other medications available?
Great question. So Prolia is an effective medicine for preventing fractures. Some of you know this. It's an injection every 6 months, generally very well tolerated. But it does have one important thing you need to know about Prolia, which is that you can't stop it abruptly. If you do stop it abruptly and don't follow it up with anything else, there is a transient period of rapid bone loss and an increased risk for spine fractures. So to avoid that, we typically transition to a bisphosphonate, something like Fosamax or Reclast, for at least a short time, like a couple of years, to prevent that rebound effect. Sometimes we may transition to another medication, but most commonly it would be to a bisphosphonate. Prolia was studied in a clinical trial called the Freedom Trial that went on for up to 10 years, and they even took bone biopsy from the women who had been on Prolia for 10 continuous years in that study at the end of 10 years, and their bone was normal and healthy. So it's safe to continue it for 10 years. We don't have longer term data than that. So we typically try to transition people off after about 10 years, but that being said, it's not a hard and fast endpoint. And I have patients that are doing well in their, 12th and 13th year of Prolia. It's just that the study didn't go any longer. There have been reports of the atypical femur fractures on Prolia, but they seem to be less common with than with the bisphosphonates. So that is somewhat of a concern. And then the jaw bone infection has been reported with Prolia as well. So again, both of those are extremely rare, but possible. So if someone were taking Prolia and needed to go off for a dental procedure, we would need to bridge them temporarily with something else. So that is the story with Prolia.
Thank you, Dr. Woods. So the next question we have here is about Evenity with the monthly shot. How much window do we have leeway in terms of getting it exactly every 28 to 31 days?
Yes, Evenity is another very effective medicine for osteoporosis. It's a dual agent, so it builds bone and prevents bone loss. It's given as a monthly injection for 1 year. There is, in the study, the protocol, I believe it was the injections were given every month, but plus or minus 2-week window. So this comes up a lot in patients who may be traveling and maybe, not available exactly on that 28-day mark. That's fine. We try to do it within a plus or minus 2-week window. But if it has to be 3 weeks, that's still okay.
Awesome. Thank you. The next question is about bone spurs and what effect our bone medication have on bone spurs.
Bone spurs, gosh. I'm not sure what the effect of the medications. Bone spurs, I would tend to think would be more associated with arthritis, and I would not expect osteoporosis medication to have either a positive or negative effect on them.
Thank you. So the next question here is asking about what gains to expect from when you are on a medication like Evenity. What are we expecting? And like after a year or?
So Evenity, let me think a moment. In the FRAME trial, which was the first trial where about 7,000 women, half got Evenity, half got placebo injections. The women on Evenity had about a 13% increase in their spine bone density in 1 year and about a 7% increase in their hip bone density in 1 year. So that really blows everything else out of the water in terms of like the magnitude of the increase in bone density in such a short period of time.
Great, thank you. The next question is asking about hyperparathyroidism and medication. So like taking Evenity, is it something that is contraindicated because of the hyperparathyroidism, or is it okay, or?
Yeah, great question. Hyperparathyroidism is a condition that can lead to bone loss. So we have 4 parathyroid glands. They sit in the neck next to the thyroid, but they're distinct from the thyroid. Their job is to regulate our blood calcium level. And calcium levels in the blood are critically important for a whole number of biological processes like nerve function, muscle function. So our body is designed to regulate calcium and keep it in this narrow normal range at all times, regardless of how much calcium is entering the system or leaving the system. Some days we might take in a lot, some days we might not take in any, and our body has to regulate it. So that parathyroid gland's main job is to protect us from low blood calcium. If we're not getting the calcium in through the diet, we will pull it in from other places. And one of those places is our huge skeletal storage pool of calcium. So our skeleton is a big bank. We store calcium there. We can deposit or withdraw 500 milligrams from that bank every day of calcium. But sometimes, especially in women after menopause, for some reason, one of these parathyroid glands stops listening to feedback. So normally when the blood calcium goes up, the parathyroid glands, dial back the parathyroid hormone production. But if one of these 4 glands is not listening to that feedback, it's going to continue to make parathyroid hormone even when we don't need it. And so the blood calcium rises. It's rising because we're telling the kidney to hold on to the calcium, we're telling the gut to absorb more calcium, and we're also pulling it out of our bones. So if we're withdrawing from the bank every day, over time that can lead to osteoporosis. So the treatment for hyperparathyroidism is to figure out which of those glands is causing the problem and to remove it surgically. You can live with even just one parathyroid gland or even a half of one gland if you really need to. But not everybody with hyperparathyroidism decides to undergo surgery. There are some cases where it's more borderline, and maybe sometimes we're not exactly sure if this is primary. What I was just describing is primary hyperparathyroidism. There's also something called secondary hyperparathyroidism, where the parathyroid hormone may be elevated appropriately because you're maybe deficient in calcium or deficient in vitamin D. Or this could happen if you have impairment in your kidney function. That's one of the effects of that. So sometimes we're not exactly sure if a parathyroid surgery is going to be helpful. So we may not send everybody right away for surgery who has an elevated parathyroid hormone level. But if you have an elevated parathyroid hormone level and you have osteoporosis, we still can address the osteoporosis. So Evenity would be acceptable as a treatment option for someone with hyperparathyroidism. The one medicine we may not choose are the parathyroid hormone analogs, which are basically parathyroid hormone. So if your parathyroid hormone is already elevated, it may not make sense to give you a medicine that is acting on the parathyroid hormone receptor. That's not 100% always true. If the case is kind of borderline, we may still try it, but that would be the one medicine we may not choose. But definitely bisphosphonates would be acceptable. Denosumab, Prolia, and even Evenity could be used in someone with hyperparathyroidism who wanted to take a medicine to protect their bones and who was not undergoing a surgery for the parathyroid.
Thank you, thank you. So we have another question.
A long answer.
I think we have 2 sides. So someone here is asking about family practice compared to an endocrinologist when it's come to prescribing bone medication. So I think we can break the question to that part. The other part is about just esophageal reflux disease, GERD, and medication and what can be done there. So I think we'll break it down to 2 questions about endocrinology versus primary care when prescribing medications, and then particular medications and GERD.
Sure. So osteoporosis is a disorder that can cross many specialties. So here at UCSD, it's primarily managed in endocrinology, also in primary care as well, family medicine, internal medicine, geriatrics, all of us manage osteoporosis. In some areas, rheumatology is really heavily involved in osteoporosis management. So, the bottom line is this is a very common condition, and endocrinologists are kind of a rare specialty. So, a lot of this care is happening in primary care clinics, and that's totally fine. Primary care doctors are equipped and capable of managing osteoporosis. And sometimes it's done by nurse practitioners. We have one here. Many of you have met her, Cassie. She's fantastic. Sometimes pharmacists are managing osteoporosis. So we need everyone and more to be involved because, it's a very common condition. And the second part of the question was about GERD. So yes, GERD, esophageal reflux, that is a common side effect of the oral bisphosphonates like Fosamax, Actonel, Boniva. So those medicines need to be taken on an empty stomach with a full glass of water. And then one would need to wait 30 minutes after taking the medicine before eating or taking other medications. They're typically just given once a week or once a month. But even if taken correctly, some people will still experience that heartburn or reflux. So a nice alternative is the intravenous form because that doesn't go through the GI tract and it doesn't cause any irritation.
Thank you. So similarly to the GERD question, we have a question about just cardiovascular health and osteoporosis medications, if there are any contraindications there or what's recommended.
Sure. The main thing to know about is that Evenity does carry a boxed warning for possible cardiovascular risk. So I mentioned the FRAME trial. That was the initial trial, 7,000 women, half of them got Evenity, half of them got placebo injections, and there was no difference in cardiovascular events between the 2 groups in that study. In the ARCH trial, the second trial, that was a smaller study with older women who were a higher risk group. Half of them got Evenity and half of them got Fosamax, and there was an imbalance. So there was some type of cardiovascular event in 2.5% of the women on Evenity compared to 1.9% of the women on Fosamax. And because of that imbalance, the FDA gave the drug a boxed warning for possible cardiovascular risk. And this is also because there is some biologic plausibility to why Evenity would influence cardiovascular risk. It is present in the vascular smooth muscle, sclerostin is. So it's controversial. We don't know if Evenity increased the risk or Fosamax reduced the risk. Some studies suggest bisphosphonates actually are cardioprotective, although they don't have an indication for that, but there's some thought that that may be the case. Or was it just chance that the 2 groups were imbalanced? So, but regardless, it's not recommended to give Evenity to anyone who's had a heart attack or stroke within the last year. Other than that, none of the other main classes of medications have cardiovascular concerns, so no risk with the bisphosphonates or denosumab. I guess the only other ones that I should mention are hormone therapy and raloxifene, Evista, do both have somewhat of an increased risk for blood clot, venous thromboembolism.
Yeah, thank you. So the next question is about Forteo and the nausea that comes with it, if there are ways that you know to manage it, as well as if there is specific body part that is best to inject in.
Yes, so Forteo, teriparatide, is one of those PTH analogs. It's given as a daily subcutaneous injection. It comes in a pen, can cause some nausea, also some dizziness, and sometimes palpitations. It does cause some vasodilation, so the blood vessels dilate, which leads to a slight drop in the blood pressure and a little bit of an increase in heart rate transiently after the injection. So things that you can do to mitigate that are make sure you're well hydrated before you take your injections. You could take them at bedtime so you can put your feet up in case you're feeling dizzy. In terms of where to inject, it's approved for the abdomen or the thigh. But really, I mean, it's a subcutaneous shot. So anywhere you have a little bit of subcutaneous tissue that you can pinch, you could inject the medication. Tymlos is the other one in that class. That one, the pen is a little bit different. So with Tymlos, you dial it up and you hear clicks as you turn it. So even though it's supposed to be dialed all the way to the end, which is 80 micrograms, you could dial it only halfway, like it's 8 clicks to get to 80. So you could do 4 clicks. So I often will tell patients, start with 4 clicks to try it out and see how you feel, and then work your way up to the full 8 clicks. With Forteo, the pen, it has a plunger, so you can't really do half of the dose. It's only you pull it out and push the plunger to administer. So with Tymlos, you can, kind of start low and titrate up, which can help with some of the side effects.
Good to know. Thank you. So we have a question thinking about hormone treatment like raloxifene, hormone replacement therapy, and the bisphosphonate, and kind of asking about how to navigate, how to make decisions among those 3.
Yes, good question. So hormone therapy is kind of a hot topic these days. The pendulum is, swung one way. Now we're kind of swinging the other way. So there's a lot more interest and discussion around hormone therapy. And part of that is because really the pendulum went a little too far when we totally stopped prescribing it. So the current thinking with hormone therapy is that the timing is important. So you want to, if you're going to use hormone therapy, you want to do it as soon as possible after menopause, or ideally within 10 years of menopause, because when hormone therapy is started closer to menopause, the benefits versus risks are more favorable. So typically, if we are using hormone therapy, now we are using the transdermal forms like estrogen patches or gels, because the risk for blood clot is lower with those transdermal formulations compared to the oral formulations. So hormone therapy does prevent bone loss. It's an anti-resorptive. In the Women's Health Initiative study, it did reduce fractures of the hip and spine. Although the women in that study didn't necessarily have osteoporosis overall, they weren't selected for having osteoporosis, but nonetheless, the hormone therapy did work. It is not FDA approved as an osteoporosis treatment. It is approved for osteoporosis prevention. So I would say hormone therapy should be considered in women generally within their 50s or within 10 years of menopause, even to prevent osteoporosis if they don't have it, but they want to get ahead of things. And if possible, we prefer the patch. Raloxifene Evista is a SERM. It's an estrogen receptor modulator. So it acts like estrogen on the bone, but anti-estrogen on the breast and the uterus. So there's no concern about increased risk for breast cancer or uterine cancer. Actually, raloxifene has been shown to prevent breast cancers in women who are at high risk. So that's an alternative for someone who doesn't want to take hormone therapy, but wants to be proactive and do something to prevent bone loss. It's also approved as a treatment for osteoporosis, although it's not the most potent in terms of increasing bone density. And in the clinical trial, it reduced spine fractures, but not hip fractures. So raloxifene is, I would say, kind of a nice option to have. It's not the most commonly used medicine, but for people who don't want to take who want something oral but don't want a bisphosphonate, it might be a good option. And then bisphosphonates, those we've discussed, they're either the weekly or monthly tablets or the once a year infusion. They are approved for both prevention and treatment of osteoporosis. They did prevent both hip and spine fractures in clinical trials. The important thing to know is that the duration of time we do need to monitor. So we're typically doing about 5 years with the oral forms and about 3 years with the intravenous forms of the bisphosphonates. And then we give what we call a drug holiday. So a person would stop taking the medicine for a few years. And that is because the risk for that atypical femur fracture is related to the duration of continuous use. So we don't want to keep you on these medicines continually. I will also say that there was a recent study in the New England Journal that showed that just giving 2 doses of Reclast over a 10-year period totally prevented bone loss in women who received the medicine. They recruited women in their 50s. Overall, the average bone density in the women in the study was in the normal range, not even osteopenia. Half of the women got the 2 doses of Reclast over 10 years. The other half got placebo. The placebo group lost 10% of their bone mass over that decade, which is what we typically see in that age group, whereas the treatment group totally maintained their bone density. So even just 2 doses of this medicine can prevent that normal, really steep drop that we experience between the ages of 50 and 60. So it's a really nice option. I just hope insurances will start covering it for women before they get osteoporosis.
Yeah, prevention is the key. Thank you. We had a good question about the relationship between dentists, dental procedure, dental appointments, and the different medications, if we need to take a break and why and such.
Such a tough question. I mean, the evidence that I read and has been reported even in the dental literature is that these jaw bone infections in osteoporosis patients are extremely rare. So most of the reported cases are in patients undergoing cancer treatment who are receiving higher or more frequent doses of these medications and may be immunocompromised from other cancer treatments. The reported incidence in osteoporosis patients on Prolia or bisphosphonates, it's like 1 in 10,000. So extremely rare. But nonetheless, if you're a dentist and you've seen a case or 2 of this, you're going to be very concerned about it. So oftentimes we will get phone calls and letters from dentists asking about these medications in patients who are undergoing teeth extractions or dental implants. Those are really the procedures that raise some concern. Routine cleanings, fillings, crowns, root canals, no problem. No need to stop anything or make any plans, just proceed. And actually, one of the best ways to prevent this jawbone infection is to stay on top of your dental hygiene and your dental care. So a risk factor for these infections is to not go to the dentist. So you want to keep going and getting your cleanings and your treatments. But if you need to have a tooth extracted and you're taking a bisphosphonate or Prolia, the dental provider may ask us if we can stop the medication. Even though the guidelines say you really don't need to stop, you can continue your treatment because it's so rare. But sometimes the dentists want to stop, so we try to work with them or at least plan the timing so that, you know, say you're on Reclast, that's a once-a-year infusion, you know, we can delay it. So the timing is not so critical with Reclast. You know, if you get it in 1.5 years instead of in 1 year, that's totally fine. So we can kind of play with the timing. Prolia, you can't play with the timing as much, but you could try to get your dental procedure done toward the end of that 6-month window. So it's tricky. It's can be frustrating for everyone involved, but we do our best to try to come up with a solution. You know, each case is unique.
Thank you. We had 2 questions about hypercalciuria, so increase of uric acid levels after some of the treatments. So just what are your intake in terms of if we can prevent, how we can treat. There is one of the questions also asking us, I think, about kidney stones as relations to that.
So hypercalciuria is a condition where the kidney is allowing too much calcium to leave through the urine. We don't really understand why this happens. There's not a genetic, you know, not a gene that anyone has found that explains this, but the thinking is that the kidney is sort of leaking too much calcium. And so that can lead to bone loss. And of course, having a high amount of calcium in the urine can also cause kidney stones. So this is generally diagnosed with a 24-hour urine collection for calcium. The treatment could include, there are some diuretic medications, thiazide. So the names of those could be hydrochlorothiazide, chlorthalidone, or indapamide. Those medicines reduce the amount of calcium that leaves the kidney in the urine. And they do improve bone density in patients who have hypercalciuria, or bisphosphonates. Bisphosphonates actually reduce hypercalciuria and improve bone density and can help to prevent kidney stones.
Thank you. So there is a question about measuring of bone quality and how those measures of bone quality relates to fracture likelihood.
Sure. So historically, we haven't had a great way to measure bone quality. We've been taught that bone fracture risk is related to bone density, which we can measure on DEXA, and also bone quality, which we didn't have a great way to measure clinically. We now have TBS, trabecular bone score, which is a software package that analyzes the grayscale variation of the spine DEXA image to try to assess the bone architecture or quality. So at UCSD, we are doing those on all of our DEXA reports now. They include a TBS score. And if you go to the DEXA school at ePark, they also will give you a TBS score. So TBS the results are in one of three categories: normal, moderately degraded, or degraded. The way I kind of think about it is if you picture the bone in your spine as like scaffolding on a building, the density is telling you the thickness of each of those rungs of the ladder or the scaffold. The TBS is telling you if they're connected or if there are gaps, disruptions in that structure. So we want to see, nice connections in the bone, and that would be a normal TBS score. If there's gaps or disruptions in the architecture, that would give a moderately degraded or degraded TBS. That's really the only clinical way we have to assess the bone quality at this time.
Thank you. There is a question about hearing loss and just tinnitus of the ear in relation to Evenity, if we know much about it and how to prevent or treat.
I haven't heard of that. Doesn't mean that it's not been reported, but I don't have an answer to that. I don't think it's a common side effect if it's related at all to Evenity.
Okay. Thanks a lot. I know we talked a little bit about hormone replacement, but there is a specific a question about estradiol and if it has any positive effect on bone.
Yeah, so estradiol is the main estrogen that the ovary produces. After menopause, mostly the main estrogen in circulation is estrone, which is a pretty weak estrogen. So when we're giving hormone replacement therapy, we are giving estradiol. It's the more potent estrogen. And we are giving, you may hear the term bioidentical hormone therapy. That used to be sort of a marketing term when the pendulum swung away from prescribing hormone therapy for women who were having symptoms of menopause and really wanted relief. Due to our failure as a medical system in addressing those needs, a lot of compounded hormone producers, went into business and marketed bioidentical hormones, which sometimes are a combination of different hormones. But really what I prescribe in my clinic and what we prescribe and generally at UCSD here, if for anyone on hormone therapy, is estradiol. It comes as a pill, a patch, a gel. Estrace is the name of the pill. So it's synthetically produced, but it is identical to what the human ovary makes.
That's awesome options. So a question here about Synthroid and Lipitor, and there is another one with also statins. Okay, so I guess there are several questions about common medications like statins and just the impact on the bone medication. So Synthroid, statins, Lipitor is a statin. So okay, Synthroid and statins, sorry, on and bone. I'm trying to collaborate a couple of questions together. And bone medications, how are those going together?
Sure. So I'll start with Synthroid. Synthroid is thyroid hormone. So for patients who have an underactive thyroid gland and they need thyroid hormone treatment, they may take Synthroid, or levothyroxine is a generic version. So the main thing, again, that's basically a bioidentical hormone. We're replacing a hormone that the thyroid normally makes, but if it's not making enough, we can give it to you as a medication. If you take more than you need and you get high thyroid hormone levels, that is not good for the bone. So hyperthyroidism, excess thyroid hormone, can lead to bone loss. also could cause weight loss, palpitations, tremors. So if you are on Synthroid or levothyroxine, whoever's prescribing it will be monitoring your levels and just make sure that your TSH, that's how we monitor your dose, is in the normal range. If TSH is too low, that means you're on too much thyroid hormone. And then statins, there's no interaction between statins and osteoporosis treatment. Statins don't cause osteoporosis to the best of my knowledge, and they also don't interfere with any of the osteoporosis treatments. So statins are commonly used for reducing cardiovascular risk, and no problem with taking those.
Thank you. So back for a second for the estradiol, the question that pop up later is if you take it vaginally, can that help bone as well?
Okay, yes, forgot to mention that. Yes, so vaginal estrogen is very commonly used after menopause. I mean, it's very, very safe, even in women who, have had estrogen receptor positive breast cancers, or, it's felt that it's safe for them to use vaginal estrogen because the systemic absorption is minimal, if at all, and that estrogen is really important for, the vaginal tissue, the pelvic floor, urogenital health, sexual health, lots of benefits. So vaginal estrogen is commonly used, and most of the formulations are just giving local estrogen. They're not systemically absorbed, so we would not expect them to have any benefits on the bone. However, there are a few vaginal formulations that are systemically absorbed, so it's important to know which one you are taking. If it is just meant for local genitourinary symptoms of menopause, or is it a systemic hormone therapy? And I don't want to say the wrong thing, but so I don't want to say the name of I think it might be I don't want to say. There's a couple of different rings, and I don't want to confuse everyone. So one of the rings is for systemic hormone therapy. So that one would benefit your bone health if you're taking that one. And then there's another ring that's a contraceptive. So we wouldn't use that for postmenopausal women, but there are a couple of rings that do give systemic levels of estrogen.
Thank you. I know Debbie's on the call too, but one of the questions was about Onero and who might be a good candidate for that program.
Deb, do you want to take that one? I don't know if you can talk.
Yep, I can talk.
Okay.
So the Onero program is unique in that there's really not a bad candidate if you are functioning in your daily life. Meaning walking around, being able to do your regular ADLs, that probably means you're a decent candidate. So there's not, if there's a recent fracture, then that wouldn't be a good idea. But if you're completely healed and released from any kind of fracture, or your doctor's released you from any kind of injury, as long as you're released for any injury, it would be fine to be assessed for it. There's no limit in terms of like, can you have a DEXA that's terrible and never be able to do it? I am sure there might be something, but I haven't seen it yet. And there's always something that we can do. So as long as you're functioning on a daily life and you're doing your ADLs and you have no restrictions from your doctor in terms of a physical injury. Now that doesn't include osteoarthritis, frozen shoulder, stuff that's left over from frozen shoulder, hip replacement, knee replacement, all of that's okay. We work with all of that. So hopefully that answers the question.
Thank you, Deb. We had a question for somebody who has some broken bones in their spine, and they're asking if there is a way to minimize damage around that when you already have a fracture.
So if you've already had a spine fracture, I would definitely, get evaluated for your bone health. Make sure there's no underlying cause of the spine fracture or osteoporosis. And I would highly recommend getting on treatment, because if you've had one spine fracture, you're at very high risk for having more. And these fractures are really bad fractures. They can, be painful. They can cause postural changes. They can really adversely affect quality of life. So we really, really want to prevent these. Sometimes spine fractures occur, you know, with lifting or something, someone will have a pop and pain and that was the fracture happening. Sometimes they can just happen gradually over time and you may not even know that they're occurring. So the vertebral bodies, you know, if they get softer and compress more than 20%, we call that a fracture. So that can occur gradually without any symptoms. But some tips that you might, you know, make you want to check to see if you have a spine fracture would be if you've lost more than 1.5 inches in height from your peak adult height, that would prompt us to order some spine x-rays and make sure that there are no vertebral fractures. So for patients who have had a vertebral fracture, if they have no contraindications, I generally recommend one of the bone building medications. If you want to learn about these in depth, I would refer you to the December Bone Health Interest Group talk, which has been recorded. You can watch that, where I discuss these medications in detail, but there's 3 of them. Forteo, Tymlos, and Evenity are the brand names for those medications. They're all excellent at improving spine bone density. They're bone builders, and they significantly prevent the risk of having more spine fractures. Spine surgeons sometimes do procedures in patients who've had spine fractures. So there's something called a kyphoplasty, where they kind of re-expand the vertebral body, and then they'll often put cement in there. The decision of whether to undergo that or not is individual and should be discussed with a spine surgeon who does that procedure. They're generally recommended for acute post-fracture pain. There's pros and cons to those procedures. So consult with the spine surgeon if you have an acute spine fracture and want to discuss whether that would be a good idea for you or not.
Thank you. And another participant who had a fracture asked about Forteo in terms of, so if you are taking those medications, is that something that you take for life?
Great question. So no, so all of those bone builders are generally short-term treatments, and you would need to follow them up with something to kind of seal it in, as we say, like a reclast, for example. So you build up the bone and then you seal it in, and you hope that you can maintain that bone that you built. Forteo and Tymlos are generally a 2-year treatment with daily self-injections given at home. Forteo, we are sometimes extending it beyond 2 years. So I've had one patient on her 4th year. It's kind of a unique case, but she still seems to be responding well. We don't have really long-term studies on the use of those medications. In theory, we think that eventually there's going to be a plateau effect, and we're not going to see any more gains in bone density. And then Evenity is a 1-year treatment. So you don't stay on those medications long-term, but you could use them again later if you needed to. So there used to be a 2-year lifetime limit on Forteo and Tymlos, but at least for Forteo, that has been removed. The concern was about osteosarcoma, which is a bone tumor that had been seen in some of the lab rats, but after 25 years of use in humans, we're not seeing that as a risk. So we are now allowed to use Forteo more than one time.
Thank you. So several questions are asking about the follow-up with the medication. So if we follow up with a DEXA scan, how often that should be, people should do a DEXA scan, and what should they expect? They should expect like no deterioration or gains, or what do we consider an effective treatment?
Yeah, good question. So there's not a one-size-fits-all answer to that question. The teaching is that you should get another DEXA scan when you reasonably expect to be able to measure a change. So with bisphosphonates, the bone density doesn't change that quickly. So generally it's every other year because we may not be able to measure a change in 1 year. That being said, as you all know, DEXA scans are very safe and it's not harmful to get one in a year, but you just may not be able, it might just say stable. You might not be able to measure a change. Now with the bone builders, those are more potent. So we see a bigger, faster change. So we typically will do a bone density after 1 year of Evenity, for example. It's only a 1-year treatment. So I like to get a pre-treatment, and at the end of that year, I get another scan. And generally I can always measure a change, a positive change with Evenity. With Forteo and Tymlos, we may do it at the beginning and at the end of the 2 years. Sometimes we'll do one at 1 year and be able to measure a change. And then, with some of the medications like the bisphosphonates, we may see an initial increase, but then we kind of see a plateau. And that's okay. If you're not having fractures and your bone density is stable on treatment, we still consider that a success. Because if you look at a bone density report, you'll see these lines that represent normal with age, and it goes down. So normally, if we don't do anything, we're going down after about age 45. So if we're maintaining and we're not on that downward slope, we're still ahead of the curve. So that's still considered success.
Thank you. There are some questions about specific areas of low bone density and medication. So if you have a hip that has a lower score than anywhere else, is there a medication that is better for that side compared to, let's say, a lower spine bone density and a medication for that?
Yes. So the teaching is really that we don't need to be treating site specifically or osteoporosis. But that being said, I do look at that. So typically the pattern we see is the spine is what, as we kind of go into menopause and we start to lose bone, the spine is what goes down first. Spine also responds more quickly to treatment compared to the hip. The spine is all that spongy trabecular bone, whereas the hip has some cortical bone, that outer dense bone, which responds more slowly. So I sort of do look at the pattern. If the spine is the lowest site, I may, and if it's really low, or if there's been a spine fracture, I may choose one of the anabolics, the bone builders, because they're really good at the spine. If the hip is low, is the lowest site, I may avoid medicines that have not demonstrated that they can significantly reduce hip fracture risk, because I'm going to really want to protect someone against hip fracture if their hip bone density is very low. So the medicines that don't prevent hip fractures, raloxifene, Evista did not show that, and Boniva, which is one of the bisphosphonates. So I wouldn't choose those in someone with a low hip score. And if the hip is really low, I may think about Evenity, because Evenity really improves the hip bone density more than any other available agent. And so if I see someone with a really low hip score, I may want to use Evenity to try to get that hip into a better range. So that's my practice. I'm not sure that everybody does that. A lot of factors go into choosing a medication, including, other medical conditions, risks, contraindications, side effects, ease of use, lots of factors.
Thank you. Thank you. I don't know, Deb, if you're still on, if you want to address, but a few people asked if you can just describe a bit more narrow. I mean, there was a whole talk about it and people can go back to that, but maybe let's just paste how to connect to people who want to hear more about it.
Sure, well, I can go ahead and put in the chat, and I can give it to you. And if you want to post it somehow, but I'll type it into the chat on how. But I did a whole presentation, and that's recorded. Yeah, in when did we do that? January, I think. So there's a whole lecture on what Onero is, but primarily in the nutshell, Onero is the only exercise program that is evidence-based that shows bone growth. So there's other programs out there that suggest balance, improves balance, improves stability, and decreases fracture because you've improved balance and stability, which is absolutely important. But there's no other study or no other program out there that has scientific evidence of bone change. So architecturally changing the bone, which is what Onero does. But you can refer back to the recording, and then I'll pop in the chat contact.
Thank you, Deb. There are several questions about just over-the-counter bone builders or collagen. And so what are your thoughts about those?
Yeah, so these are hard questions to answer because we don't always have the same level of evidence to inform us as to how effective or safe these options are. I have reviewed, not terribly recently, but a few years ago, I reviewed what was out there on collagen. Maybe it helps. The studies were small. The level of evidence I would say is kind of low, but some suggestion that could be beneficial. That being said, I will say, so the bone is mostly collagen, but if you take collagen as a supplement, your body's going to break it down. You know, you're not absorbing that full collagen molecule, so it's going to get broken down. But you know, protein is important for bone. So whether you're taking it as a form of a powder or a supplement or through your food, it is definitely important to get in enough protein. We don't, as Dr. Joss spoke in February on this, and as she mentioned, we don't really have great data to inform us on how much protein we need for optimal bone health. For muscle health, we think it's somewhere between 1.2 and 1.4 grams per kilogram body weight per day, assuming you have good kidney function. So I would kind of suggest that range for general musculoskeletal health. Other supplements that I'm asked about a lot, of course, calcium. Again, Dr. Joss's talk, if you missed it, it was in February and the recording is available. Can refer you to that. But as she showed us, most of us don't get enough calcium from our diet if we're not taking supplements. Dairy is a great source because it naturally contains calcium and protein. For people who can't do dairy, there's fortified foods. So fortified plant-based milks, for example. But you definitely want to aim for, if you're a woman over the age of 50 or you have osteoporosis, you're aiming for 1,200 milligrams a day, which is hard to get in your diet unless you're really making an effort. So calcium supplements can help us to reach that goal. We don't need to take 1,200 milligrams of calcium in the form of a supplement because you're probably getting at least some in your diet. In terms of which calcium supplements are beneficial, I mean, most of the data we have is on calcium carbonate and calcium citrate, which are Caltrate and Citracal, commonly available, relatively inexpensive. There's a lot of, you know, higher cost ones available on the internet. We don't really know that they're any better. We don't have studies comparing them head to head. So whatever works for you, just try to get enough calcium. So those are the things I would say about supplements, but many of the calcium supplements come with vitamin D. Vitamin D is not found in very many foods, and it's very safe to take as a supplement. I'd say generally 1,000 units, 25 micrograms is a good amount. If you want to take more, that's fine. But if you're taking more than 4,000 units a day, you should just I would recommend kind of keeping it at that level or less unless you're getting your levels checked. Over time, you can get high blood calcium or kidney stones if you're taking a whole lot of vitamin D, more than you need. And then strontium is the one I recommend avoiding. That competes with calcium. And so it makes your bone density look like it's getting better, but you're not building more bone. You're just swapping in a denser mineral into the bone. So you're swapping strontium in for the calcium. So the DEXAs become unreliable. And there is concern about risk for blood clot with strontium.
Thank you. Few questions about vitamin K and bone health. Do we need to take it? And if so, how much, and with medications or not, and such? Yeah.
So vitamin K is important for bone formation. You know, I do get asked this question a lot. Again, I am not convinced that we need to take it in the form of a supplement. You can get vitamin K from your diet, and also your gut microbiome produces K2. So even though K2 is only found in fermented foods, which are not that common in Western diets, our gut microbiome actually makes vitamin K2. So it's not necessary to supplement, but if you want to, it is you know, a common supplement that many of my patients are taking. I'm fine with that. I don't know of any safety concerns unless you're taking certain blood thinners that you may not want to take vitamin K.
Thank you. I do want to explain to people that, I mean, many of us wrote very specific questions about our medications and what's happening with us. We cannot really address any of those questions because you need to check with your provider. So I'm sorry that I'm skipping those those questions. I was trying to make more general questions around what we could here.
Thank you, Gina.
Thank you. So I think we addressed most of the issues that came up. I think if you feel that
Yeah, we can wrap it up. I actually do have clinic starting in a few minutes, so maybe we'll end it there. But I did want to put in a plug for our upcoming talks in May and June. So in May, we are having a talk. The speaker's name is escaping me at the moment, but it will be a talk on biosimilar medications. So in the last year, there have been a number of biosimilar medications either approved or about to get reviewed by the FDA for osteoporosis. So Prolia denosumab is coming off patent, which means that, you know, so-called generic forms can become available, but because this is a monoclonal antibody, it's a little bit different. So we don't have generics for monoclonal antibodies. We have something called biosimilars. So we're going to get a talk from somebody who is an expert in, you know, kind of like how the FDA evaluates safety and efficacy of biosimilars, because I know we get a lot of questions about generic medications. Are they as good as the brand? Are they safe? How do I know that these are okay to use? So that's what this talk will be focusing on. And then in June, we are going to hear the results of the Strong Foundations study with David Wing. So probably some of you may have been participants in that. So we thank you for your support of our team's research efforts here, and we're excited to present the data to you all.
Wonderful. Thank you so much, Dr. Woods. Thank you, amazing Bone Hub group. We'll see you again next month.
Thank you, Soshi.
Thank you, everyone.